Of course, we're going to do a little bit of deeper analysis in regard to the data as well from the CMAT component and what have we to really better understand where we are from there. But interestingly, that we are at the moment really talking, or we spoke already about 5 drugs with positive data, and 3 of them already are FDA approved, being the sorafenib already has been really the one from 2007. In regard to first line, yet to be approved, but I agree with Manish, this is expected any minute personally in regard to the lenvatinib. Then we have in regard to second line, the conditional approval for the checkpoint inhibitors being nivolumab. And we have also positive data in regard to the cabozantinib, which I expect that there will be some approval at some point in time. And of course, we have the regorafenib, which is kind of like married to the sorafenib prior exposure, but impressive data, which already is FDA approved. Quite a bit going on. And then add to this, Mark, we heard, or we got a press release talking about ramucirumab with positive data. We don't have the data yet, but at least it will be nice to at least bring 2 points about that. Any thoughts?
Yeah, ramucirumab was studied in patients who had progressed after sorafenib, and it's a pure VEGF inhibitor, monoclonal antibody, and it it just missed reaching its endpoint of survival versus placebo. But when that data was analyzed and they looked at the hazard function for survival, you could see as the AFP went up, that your hazard function survival went up. And so the company, give them credit, they did the work and said, let's do the right study. And they cut the line at 400 nanograms per ml on AFP, because that's where it seemed to be the most benefit. And REACH 2 was born, and that was the same kind of study. You've progressed on sorafenib and randomized trial, 2-to-1, ramucirumab versus placebo, and showed overall survival advantage.
So, I mean, to that question, like, tell us a little bit more about the AFP. What's AFP?
So AFP is basically a serum protein that can be quote unquote secreted by HCC. As so you talked about being an anti-VEGF, and so as your VEGF levels rise, you also can have a higher AFP. And I think this is why there's actually biologic plausibility why AFP may be a marker here. At least from a hepatology standpoint, AFP has traditionally been used more so as a screening marker or a surveillance marker. And so, we use it in combination with ultrasound for surveillance. This is, I think, the thing that's been quote unquote missing from the treatment landscape are these treatment selection biomarkers. And you've talked about it's been a decade of just sorafenib, and so we didn't need treatment selection biomarkers. It was sorafenib for all, or all advanced HCC. Now, as we start to have more and more therapies, I think treatment selection biomarkers can be helpful, and that's why we're starting to look at some of these subgroup analyses. And this is, I think the thing that's most exciting here is this is one of the few trials where we do have a treatment selection biomarker. You can say, while people can argue if it's the most sexy one or most elegant one, it's something. And so you can say AFP high, we have something that we can try to use.
And Mark, this brings me back to the lenvatinib story. Any story there in regard to the AFP level, in regard to the outcomes or what have we, that you might bring up there?
Well, in lenvatinib's study, as you mentioned earlier, that there was a disbalance. And even with randomized trial of nearly 1,000 people, it still had, the median and mean AFP value was higher in the lenvatinib arm than in the sorafenib arm.
That's important as well. So definitely more to come in that regard, and we'll see. Frankly, none of us know the data until we see it. It will be definitely, we're all going to be eager to really understand what's come from there. I would like to probably take the opportunity for each one of us, maybe 1-2 minutes, final thoughts or perspectives. So I'll start with you, Mark.
You know, I think that overall, as you introduce this section, you know, it's been a very interesting time in HCC in the last couple of years with the approval of, you know, going from one therapy to now multiple therapies. And I think what we're stuck with is trying to figure out how do we actually sequence each of these therapies at this point. What's the right approach? And I don't think there is going to be a right approach. I think, you know, there's going to be a right approach for everyone, I should say. Each patient's going to be something different. You know, some patients might be the patients that you're going to start sorafenib and then go to regorafenib, but you might actually, and maybe have cabozantinib or nivolumab later on down the road, but there might be someone that you do nivolumab second line and keep some of the other TKIs in the later on.
You bring a very impressive point. That actually, this is kind of, you know, a subject of discussion. Actually, interestingly, if anybody to ask any question to any of us is, how do you choose? And Ruth, in your thoughts, how will you choose? Exactly what Mark is asking. Like,
right now, I think we have the 2 TKIs at the front line, and we have an IO at the second line. But in the future, we may also have an IO in the first line. I think it's a very difficult question. I mean, there's really no biomarker for selection at this point. And so usually what I choose in clinic is I look at the toxicity profile. I also look how much I want to have a tumor shrinkage. If patient is very symptomatic from the disease, so I would choose some therapy with higher response rate. And then, of course, for IOs, all the patients with any history of autoimmune disease are out. So you look at all the specific, so you personalize therapy for liver cancer.
I hear you. So if anything, I agree totally that the biology is going to play quite a bit of role, and I totally agree. On the other hand, you're right. Probably at the end of the day, as we calculate our thoughts, some of the adverse events, some of the response rates might come to play. But let me ask another question, and Amit, it seems like the way, at least, which is fair, you know, Ruth is implying the same way I would have said it. TKI is one thing, IO is another. And but however, now to put it all together, are like the TKIs just competing among themselves, or does the IO stand to this?
Yeah. So I think the one other thing that I would add is there's a little bit of patient preference factor to this too. Remember that the TKIs are typically oral, and the IO therapy is an IV infusion. And so, you know, HCC, it used to be every 2 weeks. They've now gotten approval to do it every month. But, you know, so I practice in Texas, and so we have people who sometimes drive a long distance to come to our center. And so the thought of even coming once a month for an infusion for some of these patients can be more difficult. And so that is the other thing that we talk about, is just the logistical fashion of how these therapies are delivered. Going back to your point, is it like TKI versus TKI, and IO versus IO, or is there cross battle? And I think that I think this goes back, and I think the holy grail here is really if we can have response markers. And so MSI is something that can be used in other tumors. Unfortunately, you know, as Ruth said, it's pretty rare in HCC, so it's not the best response marker that we're going to have for HCC. People have talked about, going back to the whole biopsy thing, you know, you can subclassify tumors, and people think that this may be something that correlates with response. We'll see what the data bear out. I think that this is something where centers such as all the ones that we practice in have to be at the forefront of research that are looking for some kind of treatment response marker that we can say IO versus TKI, or IO plus IO, or IO plus TKI, whatever it may be. We need to do better than what we're doing. Right now we're using too gross and too inaccurate response markers to guess at who's going to respond or not respond.
I totally agree with you. If anything, it's quite fascinating. For example, take the data on the lenvatinib, 40.7% response, and we're talking the IOs on 20% response rate. And there's really one variable that might come to play. And another one, for example, for the cabozantinib. But remember, as Ruth said, it's like, you know, out of nothing, we're talking about a third line in HCC, other than the second line per se. And this advantage can carried on. So no doubt, you're right. There's quite a bit of questions to be, or answers to be brought in that regard. With this said, Manish, your thoughts?
I mean, you know, HCC is the new colorectal cancer, which is kind of cool, right? This is what I was talking to some colleagues about. You know, we have now an embarrassment of riches in terms of numbers of drugs that are effective in this disease. And the next challenge is going to be to figure out, how do we sequence them? How do we use them? The reason I use colorectal cancer as an analogy is because, of course, there's no right answer, right? You can use FOLFOX or FOLFIRI, right? Same thing here. What you're going to pick in the frontline setting, the second line setting, maybe a little bit of a stylistic preference, and that's the art of oncology. That's what makes it fun. But also, it's great for our patients to have all these options. In colorectal cancer, we ended up finding out the RAS story mutations matter. The sidedness of tumors matters. There's different biology. So maybe we'll find that in HCC. Maybe we'll really be able to identify some biomarkers. Doing the deep dive of research that Amit is talking about, I think is really important to try to say, okay, this treatment maybe work better in this patient and this treatment may work better in that patient. Hopefully we'll get to that point where we can have some science to guide us as to how to really select these therapies.
I hear you loud and clear. Great. Mark, your last thoughts.
Well, if you look at the history of the classic epithelial malignancies, breast, colon, lung, prostate, in the 60s, those were all surgical diseases. There were no drugs. Along come drugs and surgery fades. And I'm confident in a few years, some breast cancer patients will be treated with drug and radiation only and no surgery. Well, what do we have in liver cancer? Well, you can't operate because liver too sick. So we had all these IR things that we mentioned, and they're great, but now that we're having drugs, what are we going to do? Same thing. It's going to go from we're going to just whittle on your liver until you're dead to we're going to start giving you drugs in different sequences, different combinations, and we're going to patch you up for some time and downstage, potentially, and then operate. It's just like we do with other cancers.
Well, it's good. I'm very glad that you have a very positive view, and which is good for our patients. I mean, remember, at the end of the day, our bottom line is to help people. And I'm very happy to see that you're having that optimistic view. And actually, to carry on with that, I would say I'm sensing a lot of optimism in regard to oncology at this point in time. Enough that people are talking about probably an improvement in regard to survival or cure, which is kind of going into gigantic numbers by a decade or so. That's definitely probably going that direction. So I'm glad that you have that view as well. Ruth, your thoughts? Final thoughts.
So HCC is a disease, is a heterogeneous disease, need a multidisciplinary care, and we need to consider all the options, and we also need to keep our mind open for new therapies with biomarkers and biopsies. All those, I think the concept of caring for HCC is just evolving in front of our eyes, and we need to keep up with the new data.
Absolutely, quite exciting. Exactly as we started in the beginning. Out of running people likes to talk to us, which is great, if anything. Amit, your final thoughts.
Yeah, so I'm going to take a little bit of a different perspective
Please.
on this since I'm the sole hepatologist here. So I think that obviously there's a lot of excitement, and I share the optimism in terms of where the systemic therapies are going, and it's really nice to see our tools in the toolbox only rapidly expand. But I think the thing that I want to just highlight here is that at the end of the day, we want the best survival, and the best survival comes with curative therapies. I think at the end of the day, it's amazing to see the advances on this side of the spectrum, but I think the thing that we need to emphasize overall when we want to do the biggest difference for our patients is early diagnosis, early referral to treatment, into multidisciplinary care, which has been shown to improve survival, and apply curative therapies when possible. And the nice thing is, if you're not eligible for curative therapies, now we can actually look at our patients in the eye and say, we have things that are effective. We can actually prolong your survival and do so with good, tolerable drugs. But I think the key thing is early detection is important.
Well, if anything, I'm really thrilled to see that we are all rather on a positive and optimistic view, and we're all excited about the advent of the new drugs. As we said, after sorafenib, the regorafenib, the nivolumab, even though it's still conditional pending the phase 3 trial, but also the advent that we spoke quite a bit about in regard to the lenvatinib and cabozantinib. That's really incredible information. And as we heard, we are all kind of eager and keen to practice all of those drugs and help patients, and same time, of course, to even see how we can move them further forward. With this, I would like to thank you all for your contributions to this discussion. And on behalf of our panel, we thank you for joining us, and we hope that you find this OncLive peer exchange to be useful and informative.